Thank you so much. It's a pleasure to be here to see you. When I was first approached by Sharon McLaren to talk to you on these rounds, I asked her, don't you think there are many other people that you could get to speak? Why would you ask me to speak? And she said, I've heard so many good things about you, and I heard that you had a really warm personality. So I thought, that's really nice. And then I went and looked in the dictionary and looked up warm and found out that it meant not so hot. Anyways, I'll do my best to try to keep you awake here first thing in the morning, so I appreciate those that made the effort to come. So today I'd just like to go over my objectives first, which is just to evaluate normal sleep and its control, and then start to look at developing an approach for assessing sleep complaints in the elderly, assess for common sleep disorders in the elderly, including insomnia, restless leg syndrome, sleep-disordered breathing, and REM behavior disorder, and then look at some common treatments for these problems. So you might ask, what's the big deal? Well, I think Dr. Molnar already indicated why this can be an issue. Sleep complaints are among the most common reason that patients seek medical attention, and those over 65, over 2/3 of them will complain about their sleep to their doctor. In DSM-5, the sleep disorder section is the second longest section out of all the sections. I don't know if anybody's a psychiatrist here. Anybody guess what's the longest section in DSM-5? Okay, it's actually the addiction disorders. We know that nearly all of the psychiatric disorders co-occur with at least one or more abnormalities of sleep, and psychiatric illness in general have a bidirectional relationship. So a lot of issues that can be related for us. So I just want to briefly review what normal sleep is supposed to look like. So when we look at sleep into two main stages, REM sleep, or rapid eye movement sleep, and then everything else we call non-REM sleep. We know that most of dreaming occurs in REM sleep. There is also muscle paralysis. So all of our muscles are completely paralyzed or atonic, and that is normal. We don't know what the function of REM sleep is, but a lot of people believe that it might play a role in modulating emotional memory and maybe playing a role in affect regulation as well. So obviously that has significant implications for psychiatry. When we look at non-REM sleep, we divide this into now 3 stages. N1 and N2 are light stages of sleep, and N3, is sometimes called the deep sleep or slow wave sleep. This is the most physically restorative or cerebrally restorative stage of sleep. Interestingly, this decreases with each passing decade by about 2%. So for those that are younger in the audience here in your 20s, enjoy it. That's your peak because it keeps going down with each decade. So this is just a picture of what normal sleep looks like on the top here for a normal, young, healthy person. I don't know if you can see this arrow here. And then in an elderly person, the sleep architecture really changes. And the main changes that you can see are that for the elderly person, it takes longer to fall asleep. There are more fragmentations of sleep, so whenever the line comes up to the W, that means they're awake. So you see a lot of these spikes here in their sleep, meaning that their sleep is less efficient as they get more deep sleep. In the first part of the night, you see very little deep sleep here for the elderly person, and there's less REM sleep overall. REM sleep are these black bars here, and interestingly, in the young person, there's more REM sleep in the second half of the night, less in the first. In the elderly person, the REM sleep is more uniformly distributed. So we're just losing that normal sleep architecture in the elderly person, and sleep overall is just less efficient as we get older with less deep sleep. So how much sleep is a common question that I always get. The National Sleep Foundation has put out guidelines for what a normal sleep requirement is for people. So if you look at this is just in 2014, they released this, the normal adult, which I think where most of us here fit from what I can see, 26 to 64, the recommendation is 7 to 9 hours. Some people can get by on 6, some people need 10, but you see for the elderly, it's actually 7 to 8 hours. And they're getting by on maybe 9 hours. But it's not that they need less sleep. They actually need the same amount of sleep as the younger person. This is what a lot of studies have demonstrated. But their ability to sleep decreases as they get older. So they become less efficient sleepers as they get older. So they're not able to obtain the appropriate quantity of sleep that they would otherwise need. So in general, it means that they're all sleepier compared to a younger person. So I just want to briefly review how sleep is controlled. So when we look at sleep control, it is governed by 2 main processes. One called process S, which I think stands for sleep, and another one called process C, which stands for circadian. So Process S is fairly easy to understand. It's called a homeostatic control, and basically posits that the longer we're awake, the more sleep debt we accumulate, and so the sleepier we become. So if you look on your left here, normally first thing in the morning, you're very awake because hopefully you've had a good night's sleep last night. But then as the day progresses, you start to accumulate a sleep debt. And then as that sleep debt accumulates, your wakefulness will decline. Sleep debt grows larger, and then that will tip the scale eventually towards sleep debt, until finally when the night approaches, then you can have a good night's sleep, pay off your sleep debt, and this is where you would sleep. And then once that sleep debt is paid off, then the sleep debt is small, and once the sleep debt is small, your wakefulness improves, and then the scale shifts back to wakefulness again. So this is very much like hunger, right? The longer the day goes, the hungrier you become, and then once you eat something, then you satisfy it, and then the cycle kind of starts again. And right now, to date, there's no known surrogate available for good quality sleep. All of these things that we do that we think help us to stay awake, use caffeine or coffee or maybe even cocaine or something like that, they are not surrogates for good sleep. They only mask sleepiness that's otherwise there. So if that were the only process that would be going on, we'd always be the most awake in the day and most sleepy at night. But we know that's actually not true. Sleep tendencies also tend to follow a circadian rhythm that is controlled by a central biological clock called the suprachiasmatic nucleus, or SCN. And several inputs also influence this clock, especially light and melatonin. So if we look at this more carefully, so I outlined it here. This is a suprachiasmatic nucleus. It's a very small organ inside the hypothalamus. It receives input from something called the retinal hypothalamic tract, which is basically connected to the eyes. And the eyes sense light. And so light is a major, what we call Zeitgeber, or entrainer of this circadian rhythm, sends output to the suprachiasmatic nucleus, but it also receives input from the pineal gland, which is a really tiny calcified organ near the dorsal part of the brain. And this also sends input via melatonin to the suprachiasmatic nucleus. And these two forces work together to regulate the circadian output of that circadian suprachiasmatic nucleus. So melatonin is basically the hormone responsible that responds to darkness. So when light fades and darkness ensues, then melatonin production increases. And then these two inputs work together to regulate that circadian output. So there are photoreceptors in the eye, several which include melanopsin, that are very sensitive to light, especially the 450 to 480 nanometer wavelength, which is actually the blue light. And so this is why light exposure in the late evening hours can disrupt or delay the sleep. So people, for example, who look at the computer or video games or things like this, that can actually cause insomnia for some people because that light from the screen is powerful enough and usually at the right color. Often it's blue light. It's my conspiracy that Bill Gates actually made Microsoft Windows have a blue background to make sure people are looking at his screen at night. But this light, you trick the brain into thinking it's daytime, suppress melatonin production, and cause insomnia for some people, because when there's excess light, melatonin production from the pineal gland drops significantly. So if people don't sleep at the right time relative to their own circadian cycle, well, what happens? We know the sleep continuity is poor, there's drops in alertness, more cognitive errors, more mood disturbances. I compare it to like fishing at the wrong time. Even though you're doing the right thing, if you're doing it at the wrong time, it's just not as effective. And if you want to experience these effects for yourself, just go to a different time zone. Fly to Vancouver or London or Italy, or do shift work. How many people do shift work here? Anybody? Or has at least done some night shift once or twice? Okay, at least a few. So if you want to know what asynchronous sleep is like, just think about what your sleep is like after a call. Even though you sleep maybe 6 hours or whatever after your call, it just doesn't feel the same as when you slept during the night. So just to reiterate, the consequences of aging with respect to our sleep is that our need for sleep stays the same, but our ability to sleep decreases. And then another interesting thing with the elderly is sleep phase advances with the age. So there's more of a tendency to need to go to bed earlier and wake up earlier that advances with each passing decade. Okay, so I just want to talk about insomnia now. It's a common problem that we run into. A major paradigm shift in DSM-5 in the sleep disorders is that now you can diagnose insomnia disorder as a separate entity. And this comes from several studies that demonstrated that for those who had a mood disorder, for example, and insomnia, if you treat the two symptoms or two disorders separately, we achieve better outcomes in terms of relapse prevention than if we only treat one or the other. DSM-4, insomnia was always thought of as sort of secondary to a mood disorder or to an anxiety disorder. But once these studies came out in the DSM-5, a major change was now you can diagnose quality or quantity of sleep with at least one of difficulty, significant distress for at least 3 times a week for at least 3 months, not due to more inadequate sleep time. When we look at the clinical presentation of this, often, unlike Yakin's razor, it's multifactorial in origin. So there's predisposing, precipitating, and perpetuating factors. So there may be a primary sleep pathology. Often there's an acute stress comes on. Medications may play a role, and there's psychiatric disorders, behavioral. You notice age here is also an issue. All of these factors work together to contribute to an of hyperarousal that perpetuates or precipitates the development of insomnia. That's how we imagine insomnia as a whole in development. So when we look at management of insomnia, an overall approach is to look at assessment and diagnosis. Our first trying to address some behaviors, including some hygiene issues, sleep hygiene issues. I'll go over that briefly. We use pharmacologic therapy, and at times it may introduce a sleep specialist to if problems persist. So one thing about sleep is that the drive to sleep is actually very strong. It's almost as strong as the drive to breathe. So the things that can sabotage sleep are often things that people do that they might. For example, things like I mentioned, looking at the computer, even cognitive distortions about precipitate the state of arousal. So sometimes the can be really helpful. So it's really recommended to be tried first, but the problem is they take more exertion to you as a case point of discussion. Mr. K, an interview with him, and I'll see if this works here, and we can see what his insomnia complaints are.
Thank you very much for agreeing to be interviewed here. So, can you tell me what is a sleep clinic to be seen today?
I was having problems sleeping at night, wake up 2 or 3 times during the night, and I wasn't getting a good night's sleep. And I had a big operation 4 years ago, and main artery, and I was in a coma for 14 days. Spent 2 months in the hospital. Problems have arisen since then.
Okay, so the problems began after you had that big
I believe they started.
procedure.
I've never been agreed to sleep over 20 years. And I got used to the from around the career. And when I changed, I went back to college, get my degree on courses, and to get on better shifts. My sleep got a lot better when I was not doing night shift. But I've never been a sound sleeper. I'll wake up at the drop of a hat. I hear it always.
Okay. And right now, are there any stressors going on for you that you think might contribute to your sleep problems?
Stress, yes. I have a lot of stress lately. Family issues. Caused by other family members, just caused me a great deal of stress. And my doctor operated me 3 times so far, advised me to get rid of the stress, which I did. Twice. And though I still feel the effects of some of the stress I'm not going to talk to 3 members of my family, it does bother me. It does really do. But I've learned I can't change what's happened.
But even getting rid of that, you still feel like you have sleep problems?
A little bit. I was having sleep problems.
Okay, so just a fairly common kind of a history, but I want to go over his interview on his sleep inquiry, so see what he talked about there.
Well, let's just go through your sleep. We'll see if there's anything we come up with. So what time do you normally go to bed?
Between 10 and 11 at night. And I usually wake up between 7 and 8 o'clock in the morning.
Okay, and how long does it take for you to fall asleep at night?
I read a book.
Okay, so falling asleep is really not that much of a problem, but it's been staying asleep, I guess.
I wake up usually once during the night, sometimes supposed to go for a pee, and then I fall back asleep.
Okay. And I just want to ask your wife some questions. So, during the night, does he snore?
Yes.
How loud? Okay. Quite loud? Okay, you can hear it outside the
I
window?
can hear him stop. Like sometimes I have to go, are you still alive? Like, stop breathing.
Okay.
Wait a minute.
Okay. All right. Does he do anything else unusual at the night? Sleepwalking, sleep talking? Okay. Tell me about.
He doesn't get out of bed or just get up and wander around. His legs start to twitch, and then all of a sudden he'll be awake, and you'll hear that horrible snoring as he goes back down again.
Okay.
So it's not a continuous sleep.
Okay.
It is very much disturbed sleep.
So you got a lot of leg twitching at night?
Absolutely.
Okay.
Absolutely.
But it's not acting out dreams or hitting you in sleep?
No. A couple of times he has done, like sometimes he just automatically will swing out at something, so he's probably dreaming about something.
Okay.
And all I have to do is just this.
Okay.
And that's it.
And during the day, does he look fatigued to you or sleepy?
Oh, I find he sleeps at the drop of a hat. And can when we're sitting in the chair, like that, he's like, "Put the chair." Watching TV. I think we get it. It's just a normal
Okay, so it gives some information. The partner history is very important. So just a little more history on him. He, as far as his medical history, is osteoarthritis, and he's referring to this peptic ulcer disease. He had a severe upper GI bleed where he had to be hospitalized for this, but he recovered from that reasonably well. He has hypertension, hypercholesterolemia. He's on cholesterol medications and blood pressure pills and reflux pills. I think someone still hasn't turned off their mic out there. The person who coughed there, wherever you're at, I think you didn't turn off your mic, so we heard that cough. For a psychiatric history, he had a remote history of alcohol problems, but he's been sober but there's been some cognitive decline noted for the last 3 years, so he was actually consulted by a psychiatrist, and it's a psychiatrist who actually referred him to us for an assessment. He's still having a retired police officer, no real I want to keep his case in mind, and we'll come back to him a little bit later. So if we look at insomnia in the elderly, we know that in general the women outnumber the men. For insomnia in the normal population, it might occur in 12 to 20% of the population, but up to 40% of people over the age of 65 may have this as a clinically significant issue. Medical and psychiatric conditions play a key role in the development of insomnia. A large review by Foley and colleagues on 6,800 elderly patients showed that among those who had a clinically significant insomnia, only of them didn't have one of depression, chronic pain, cancer, COPD, or cardiovascular disease. They almost always have one of those conditions. The consequences of this, as not alluded to, are significant for the elderly. Poor attention and memory, decreased response time, more fall, and anxiety. This is quite significant for this group. We know that sleep disturbances, the elderly, are a strong predictor for subsequent development of cognitive impairment, although there are some studies that actually show no disturbance. Very interestingly, very novel studies have linked sleep fragmentation with excess beta amyloid deposition. And for those that don't know, beta amyloid is one of the pathologic targets that is thought to be implicated in the development of Alzheimer's disease. Interestingly, there's a U-shaped association between sleep duration and cognitive problems. So those that get less than 7 hours or more than 9 hours of sleep have more association with cognitive impairment. And what's gotten more media attention recently is that benzodiazepine use has now been associated with the onset of Alzheimer's disease. But what's not really clear is whether it's the insomnia that maybe causes the subsequent development of Alzheimer's or other cognitive problems, and maybe benzodiazepines are being used to treat that, or could insomnia be a marker or a prodrome for the subsequent development of Alzheimer's? So maybe that's just the earliest symptom of the cognitive disorder that's developing. And then this last study kind of hints that maybe it's actually the benzodiazepine use itself, perhaps, that causes the insomnia. But that question is not really clear. But there's something there that is an association in any event. So there are a lot of circadian rhythm changes that occur in the elderly. In general, that circadian system becomes less robust and more prone to advancing, as I mentioned. And so with this, in the elderly, two patterns can develop. So I tried to show this in an illustration here that I added at the last minute. But if this is the normal sleep pattern, you go to bed at 10:30, wake up at 7. In the elderly, they have a tendency to maybe want to go to bed earlier. This is a little far advanced, but 7 p.m. and waking up at 3 a.m. But With that kind of advancement, these two patterns can develop. So one is very inconvenient for the elderly to go to bed at 7. So they might try to stay awake longer and then go to bed here, but they still have this cortisol push because of their advanced sleep phase that will wake them up in the middle of the night. So that can be a problem, and then that leads to more fatigue and sleepiness in the day. What can also happen is because they feel fatigued earlier, they might actually have a nap, perhaps around here, and then if they have the nap, they have less sleep debt to consolidate their sleep that night, and then that can make insomnia problems worse. So we know that sleep and insomnia has also been associated with cognitive disorders like dementia, and there are several factors that might play a role in interrupting that sleep at night. So especially for elderly patients in nursing home, we know that they have less exposure to light, and there's excess noise in nursing homes as well. They're on a lot of medications which can aggravate insomnia as well. That suprachiasmatic nucleus also tends to degenerate as people get older, and there's even a profound reduction in melatonin production as people get older, up to 80% reduction of melatonin in the elderly. So there is something that is really just degenerating with that circadian rhythm that makes the elderly more prone to developing insomnia and circadian rhythm disturbances, and a lot of evidence to attest to that fact. So if we look at treatment for insomnia, as I mentioned, the first step really is to go over that sleep hygiene more carefully, but it takes a lot of effort and energy and often is overlooked. Really insist that they have regular sleep and wake times, try to avoid daytime naps, or if they nap, to keep it under 30 minutes to reduce the decreased homeostatic drive for sleep that following night. Try to tell them to avoid clock watching. This is a common issue because sleep is a funny thing. The harder you try to sleep, the worse your sleep is. And so what happens when they look at the clock, oh, it's 2 o'clock, why am I awake? It's 3 o'clock, I'm still awake. It's 5 o'clock, I can get 2 hours of sleep. It makes them think more about their sleep, and the more they think about it, the worse that is. And we also tell them to avoid alcohol and caffeine. These substances, and smoking for that matter as well, also disrupts sleep too. Really important, especially in the elderly, to maximize the daylight exposure and minimize light exposure in the evening. There are some elderly who they do a lot of stuff on the computer, for example, late at night, and they don't realize, especially with their circadian system being less robust than younger people, that they're more prone to that effect of that light on causing insomnia for them. Exercise is also very important. Exercise generates more homeostatic drive for sleep in the subsequent night. If we have to be more aggressive, then cognitive behavioral therapy can be used. And then we can use medications in selected cases. But to me, that's a whole other discussion in and of itself. So I want to change tracks a little bit and talk about the sleep disorders in the elderly that can be common. So I'll talk about breathing-related sleep disorder, restless leg syndrome, and a related condition, periodic limb movement disorder, and REM behavior disorder. So I want to first talk about breathing-related sleep disorder. This is what it's called in DSM-5. We all know more commonly as obstructive sleep apnea. So obstructive sleep apnea occurs when there are repeated pharyngeal obstructions with airflow cessation. This is what we call an apnea, or partial reduction, a hypopnea in the night. We measure the severity of this with an index called the apnea-hypopnea index, which is the frequency of sleep-disordered breathing events per hour of sleep. And generally 5 to 15 events per hour is considered mild sleep apnea, 15 to 30 is moderate sleep apnea, anything over 30 is severe. But then there are also partial hypopneas in the night that can occur without a reduction in oxygen saturation, but associated with an arousal. That also can be included in another index called the respiratory disturbance index. These are called respiratory effort-related arousal. This is another kind of sleep-disordered breathing event that can occur. So the common symptoms of sleep apnea, this is very familiar to most clinicians, but snoring. But some patients with sleep apnea don't actually snore. Only 80% of them will snore. They can either have sleepiness or insomnia at night, and sometimes they'll complain of insomnia because what's actually happening is they're having repetitive apneic events and waking up in the middle of the night, but they feel like they're not sleeping at all, but they're actually going in and out of sleep throughout the night. Clearly, witnessed apneas from a partner is a very suspicious sign. They can wake up with morning headaches because when people have apneic events, there's an accumulation of carbon dioxide, and that carbon dioxide causes a distension of cerebral blood vessels that can be felt as a headache, and then during the day, when they ventilate, they blow off the CO2, and then the headache symptoms are reduced. Interestingly, they go to the bathroom frequently at night. When people have apneic events, they put a strain on the heart, and the heart starts to produce a hormone called atrial natriuretic factor, which causes people to go pee. And so one of the first things we often see when we get sleep apnea treated is they don't have to go to the bathroom as much during the night. So people going to the bathroom is not necessarily a symptom of prostate or bladder issues. Sometimes it's actually a symptom of sleep apnea. They often wake up with a dry mouth because they're trying to breathe at night. They can have memory complaints, maybe because of a lack of oxygen or sleep fragmentation that occurs at night. And something we're interested in is irritability and depression has also been associated with sleep apnea. But if we look in the elderly population, the symptoms they complain more about are morning headaches, bathroom breaks, memory complaints, and irritability and depression. So they don't necessarily have some of those other symptoms that might be more commonly seen in a younger patient population. So the interesting thing about sleep apnea in the elderly is the prevalence rises sharply with age. In the normal population, depending on the study you look at, it might be anywhere from 4 to 25% of people might have sleep apnea, but in the elderly, this can occur in almost half, or up to half of people, or even more, for those between the ages of 65 and 95. And this is due to many different factors. They often have more medical conditions that can predispose them to sleep apnea. Renal failure has been associated with this, obesity, and even neurocognitive disorders because those patients have more brainstem degeneration. The brainstem is where the muscles that innervate the facial muscles or oropharyngeal muscles also emerge from. So when that degenerates, they have less innervation to those muscles. So with age, there's less innervation to those muscles that innervate the pharyngeal dilator muscles, for instance, so they're more collapsible. And menopause has been associated with sleep apnea as well. So if you look at the prevalence of sleep apnea in the premenopausal population, the men outnumber the women by about 2 to 1. Post-menopause, that ratio becomes 1 to 1. So there is something about the female hormones that we know about that protects them from sleep apnea, but women will lose that protection once they hit menopause. So with sleep apnea in the elderly, most cases are diagnosed. Usually, just the symptoms that I mentioned, they're quite vague. They're often overlooked as just part of aging or secondary to some other medical conditions because, like we saw in the video there, this is just thought that's just a normal part of aging. So another interesting point about sleep apnea is 40% of patients with sleep apnea between the ages of 40 and 98 are not obese. They have a body mass index under 27. I'm going to put that in context. My BMI is 26, so it's not necessarily that they have to be overweight, and we know that obesity only accounts for 1/3 of the variability in OSA in the older population. And so the statement by Terry Young and colleagues, Terry Young is the one who did most of the epidemiologic work on OSA, said that obesity may be particularly insensitive for identifying OSA in older people. And we know that that association between OSA and body habits actually decreases as people get older. So what do we have for treatment for obstructive sleep apnea? Well, the commonest treatment we use is something called continuous positive airway pressure. I'll just show you what this is here with the video.
Snoring happens when the back of your tongue and throat relax and restrict airflow. If you have sleep apnea, your throat relaxes to the point where it can cut off breathing. A CPAP machine is a device you wear over your nose. It pumps air in and keeps the back of your throat open.
So it's basically just a glorified fan that can, keep the airway open. It's a very effective treatment. This is what a modern device might look like. So it can be hopefully reasonably comfortable. Obviously, it's an idealized picture there. Weight loss can be really helpful for those that are overweight. There's a direct correlation between a decrease in body mass index and a decrease in the respiratory disturbance index or frequency of events at night. We tell these patients to avoid alcohol and sedatives and muscle relaxants because those substances can increase the relaxation of muscles of the upper airway, precipitating collapse. Sometimes if people only have sleep apnea on their back, they can use a snorball technique, which is where you wear the t-shirt or some similar clothing with a pocket in the back and you put tennis balls in there so you avoid sleeping on your back. I've had some patients, they tell me they cure their sleep apnea by going to sleep wearing their wife's bra to bed. Like, really? And like, oh yeah, doc, it works for sure. And all they do is they put their wife's bra on, they stuff it with tennis balls, and they turn it around. Like, okay, if that works for you, I'm sure that's the only reason you use it. So, but it can, if it's mild and only positional, then sometimes that can be helpful. So there are oral appliances that can be used. These are devices made by dentists that snap to the teeth but advance the lower jaw forward like this. So you give people a really severe underbite, in essence, to kind of open up the airway. The same principle is used for CPR, for example. When you give people resuscitation, you do the jaw thrust to kind of pull the lower jaw forward, so they can be effective in mild or moderate cases. There's a fairly new treatment that people may not be familiar about called Provent, and I'll just show a little video showing what this is.
Introducing Provent therapy for obstructive sleep apnea. Provent therapy is an innovative new treatment for obstructive sleep apnea that utilizes nasal expiratory positive airway pressure, or EPAP. Provent therapy is a disposable device that attaches with a hypoallergenic adhesive over the nostrils. The proprietary microvalve technology uses a person's own breathing to create EPAP. During inspiration, the microvalve opens, allowing for nearly unobstructed airflow. Then, during expiration, the microvalve closes, partially restricting airflow to create EPAP and maintain pressure in the airway through the start of the next inspiration. This helps maintain airway patency during sleep.
So it's just another alternative that we have for treating sleep apnea. It's relatively new, only came out in Canada in the last 1 or 2 years. In certain cases, there can be upper airway surgery. Tonsillectomy is used, especially in the pediatric population. There's something called a uvulopalato-pharyngoplasty procedure, where the ENT surgeon just goes out and carves out this uvula to kind of open up the airway, and that can be helpful maybe in mild cases of sleep apnea. So I want to change tracks a little bit and talk about restless leg syndrome, also called Willis-Ekbom disease, and a related condition called periodic limb movement disorder. So restless leg syndrome did make it to the DSM-5 as a primary diagnosis. In DSM-4, it's called dysomnia not otherwise specified. But the symptoms of this can be remembered by this mnemonic, URGE, which is published by Dr. Allen and colleagues. But the U stands for an urge to move the legs. The R is for rest. Symptoms are worse at rest, so long car rides or long plane rides or sitting in a lecture like this might cause, I don't see anybody has it, but it's the morning, so it's usually not common in the morning. It gets better with movement, so people move around or massage their legs or apply a counter-stimulus, gets better. As soon as they stop doing that, it can come back. And worse in the evening. Often people can pick a time when their legs bother them the most. At least 3 times a week, at least 3 months, significant distress. So we know that the prevalence of this rises sharply with age. The study by Allen and colleagues from Johns Hopkins, they showed that the primary age group is maybe the 50 to 80-year-old group. The yellow is all of them, but the women outnumber the men by 2 to 1, and this is consistent across the decades. There's a related condition called periodic limb movement disorder. I could explain it, but I think it's just easy to show. So this person is sleeping in the right lateral decubitus position at night, and they could be sleeping very calmly. And just imagine if you're this person's partner, and sleeping soundly, and all of a sudden they do something like this. Kick their legs a little bit. 30 seconds later, the same thing might occur again. And it occurs throughout the night. Very disruptive for the person sleeping with them. So the leading hypothesis for both of these disorders, thought to be related, is there's some kind of problem with CNS dopamine dysfunction. It probably involves a circadian mechanism. That's why it occurs at nighttime, and probably deficiencies in iron actually play a role. Iron is one of the cofactors for the rate-limiting step of dopamine synthesis for an enzyme called tyrosine hydroxylase. So this might be one of the explanations why women are more likely to have this. They're more prone to iron deficiency. They're more prone to make changes in their diet, being vegan or vegetarian, menstruation, or sometimes they choose to share their iron supply with a fetus in their life. So as far as treatment for RLS, we want to address the exacerbating factors. Caffeine, tobacco, and alcohol are all known triggers for this. Any medication that affects dopamine can affect us, so we use a lot of these in psychiatry, like the antipsychotics, but interestingly, many of the antidepressants will also exacerbate RLS and periodic limb movements, like SSRIs, SNRIs, TCAs, and actually especially mirtazapine, which sometimes can be an issue for the elderly. We often use this for sleep induction for the elderly, but in some cases it can exacerbate insomnia because it's actually triggering periodic limb movements or restless leg syndrome at nighttime. We want to check their iron supply, look at the intake, look at absorption issues like GI problems, any kind of blood loss, anemia, looking at cough or hemoptysis or lower GI bleeding periods. This is not an issue for the elderly, obviously, or blood donations. And we want that ferritin to actually be above 50 micrograms per liter. That's an indirect surrogate measure for CNS iron. But the normal ferritin in the blood lab you see is usually a range between 20 to 200, but patients with this kind of problem, they need a normal iron level, not a low normal. So sometimes we've seen in some elderly patients, I've seen that they have a lot of periodic limb movement, but it can actually be a marker for iron deficiency. And then once they check it, then I've had some patients go on to find they had some actually underlying GI bleeding that wasn't known before. And the first sign was actually leg kicking at nighttime. So if we look at pharmacologic treatment options for RLS and PLMD, dopamine agonists are usually our primary choice if we can use these depending on the severity of symptoms. Pramipexole is my personal favorite, but L-DOPA can also be used in select cases. Gabapentin or pregabalin are alpha-2 delta drugs that are also very effective. Benzodiazepines and opiates are also very effective. They're usually third or fourth line agents, so mostly because of the side effects, not because they don't work. So, okay, just change tracks a little bit and talk about REM behavior disorders. So recall in REM sleep that there is muscle atonia. In RBD, there is no muscle atonia. I always found this confusing because no atonia is a double negative, means they're not paralyzed, so they have the ability to move and have the ability to act out complex dream behavior, and then often the bed partner is a victim. Interestingly, patients are, 90% of them are men, and it usually comes on in the older decades, 50 or 60 years old. What's really interesting is that the level of aggression demonstrated in the dream enactment often varies inversely with the person's personality. In other words, they're usually the nicest, kindest people during the day. They're very soft-spoken, but at night you see the really wicked, violent dreams and punching and kicking at night. So it kind of begs for some kind of psychodynamic theory of suppressed rage, but we know that's really not true. What is true, though, is that the sign of RBD has a very strong association with the subsequent development of alpha-synucleinopathies like Parkinson's disease or Lewy body dementia or multisystem atrophy. Some authorities believe that if you let these people live long enough, all of them will actually develop one of these problems. So it's thought that maybe the pathology of those alpha-synucleinopathies begins in the brainstem, which is where the REM sleep control system occurs, and then over each passing decade spreads across the nigrostriatal area. So when we evaluate this in the sleep lab, we want to do a full EEG montage with the sleep study to rule out seizure activity. Ideally, we do head imaging to rule out lesions in the brainstem that may cause the problem. Make sure the environment is safe. Possibly put mattresses on the floor. They often will fall out of bed, or maybe restraints. Bed partners should sleep in another room because often they can get hurt by these behaviors. If we have to use pharmacologic treatment, clonazepam is a very effective treatment for this. Even a low dose, 0.5 or 1 milligram, is often very effective in 80 to 90% of cases. It's not always an ideal choice in the elderly, though, because of the side effects. Our next best choice probably is melatonin. We don't know why that works, but in up to a third to half of cases, it can be very effective. After that, it's getting pretty sketchy in terms of medication options we have. Some studies suggesting Mirapex could be helpful, which is pramipexole. So just to summarize, for the sleep disorders, for some screening questions, if you are concerned about this in your clinic, for sleep apnea, I think 2 key questions. Do you snore? First, and number 2, does your partner complain about your sleep? For restless leg syndrome, do your legs bother you before you go to bed? Does your partner complain that you kick at night? For RBD, does your partner say that you do anything unusual at night or falling out of bed? If you can look at those can be helpful. For an insomnia assessment, ask about when it started. Often there's a trigger or a stressor. Look at a brief sleep inquiry. I demonstrated one there before, going to bed, waking up. During the day, how is function? Any evidence of mood disorder, anxiety disorder? Those are the most common ones associated with insomnia. But the partner interview is very important, right? The partner gives a lot of information, but often the etiology is multifactorial. I just want to go over our patient's sleep study results there. So this is the sleep hypnogram here. So we actually have a pretty reasonable sleep architecture. We saw 4 REM sleep cycles here. REM is in the green. Deep sleep is the N3 here. So there's a little bit to here, but lots of fragmentation, a lot of breathing events here, which is this bar here. The oxygen saturation at night, normally there should be a straight line between 90 and 100%. Pretty reasonable looking. There's some mild disruptions here with the breathing events. We're looking at its position. There's some events. We also said AHI was 5 as RDI was follow-up interview for this person, see what he did.
We went over your sleep study results, showed that you have some sleep apnea. I guess you were able to try the CPAP now?
Yes, I did.
Okay, how did that go for you?
Started with thinking about it didn't improve my sleepiness.
Okay.
But it was just a pain in the butt. It was, I think it was waking me up more than 5, 6, sometimes 7 hours a night.
Yeah.
Every day, basically.
Okay. How long did you use it for?
I had it for roughly 2 weeks.
2 weeks. Okay. And you said that there were some improvements in your those were?
I woke up feeling more refreshed.
Mm-hmm.
But like I said, I used to it. I found it was, I have to use this thing permanently. It was,
Okay.
it's more of a pain in the butt than anything else.
Okay. And I guess you noticed also some, did you notice anything with his sleep when?
I noticed he wasn't as restless.
Okay.
He was a lot calmer, and the legs still danced, but not to the same severity.
Not as much.
And he seemed to be, when he was well, he seemed to be a lot more alert.
Okay. All
And
right.
that's, I think, where the difference kind of showed that he was asleep.
And that the CPAP was causing you so many problems that you went out and got kind of a dental device.
I went to the pharmacy. I looked up when I first saw the sleep device on it. No free sleep and I bought it, and I used it, and I found that I got better in the CPAP.
Mm-hmm.
And where I had no shoes to bother me,
Mm-hmm.
I'm very good at sleep.
Mm-hmm.
And I wasn't getting up as much.
Okay. This appliance, do you notice anything about his sleep? Was it similar to CPAP, or is he kicking still a lot at
The
night?
kicking was still there, not as frequent, but it was there. And I would also say to him, get off your back, get on, because that's when I found he had a lot of problems with where he's on his side is not as.
Okay, so I have a poll here, but in the interest of time, I'll maybe skip the poll. So on his oral appliance, just to see, is this really working for him or not? I mean, got it at Walmart, how good could it be? Well, surprise, it's actually quite effective. Most of the events are actually gone now. He has a few in REM sleep and a few on his back that we see here, just like the wife said. But if he's off his back, it's very reasonable. The AHI was 3, so it's under 5. The RDI is just below 10, so it's probably okay. Still has a lot of leg kicking though here at night. So we decided to try to treat that and see how he did. So.
Okay, so welcome back. So I guess that medication that we had talked about.
Yes, it did.
Okay, so I think the medication you're trying to prescribe Paxil, as I recall. How did that work for you?
I started with the small doses, like you suggested there, half a pill. And I worked up myself up to 1 pill. I don't take 2, 1 pill. And I think it's working. I'm sleeping anywhere between 6, 7 to 9 hours of good sleep. I did right through it. Damn cat woke me up. When I was here, I slept good until the technician woke me up. And I don't think I'm twitching as much as I did before. My wife would know. Because I don't wake up anymore. If I do, it's very, like I said, very self-cat. Other than that, I won't wake up. So I think the pillows work great.
Okay, have you had any problems with the pill at all?
No problems at all.
No? Okay. Have the differences, what have you noticed?
I noticed that he seems to be a lot calmer, and because he takes it earlier in the evening, when he does finally get into bed, it's a lot more relaxed than what he normally would be tense, reading about, blah, blah, blah. And now he seems to be a lot more relaxed. I very seldom feel the twitching or the kicking of the legs, very seldom.
Oh,
Yes, it has. It has improved it greatly.
okay, right.
For me, yes.
Okay. And so I want to ask right now, do you feel satisfied with your sleep?
Yes, very.
That's our final question.
Yes.
That sounds great.
Okay, so just to summarize, we know that sleep changes with the elderly. Sleep need is stable, but sleep efficiency goes down. Insomnia is very common, may be related to multiple factors. Sleep disorders, especially sleep apnea, but also restless leg syndrome, periodic limb movement disorder, RBD, are more common in the elderly, but careful assessment is very important, especially the partner. If you realize in his story, the partner actually gave everything. If you only looked at him, you might think about stress and maybe depression and things like that, but she gave the real history that was very helpful in his evaluation. So that's all I have. This is one of my sons here studying to be a sleep doctor very early, so we'll see. I'd be happy to take any questions. And